Welcome to the Department of Population Health Sciences podcast here at King's College London. I'm Dr. Martin Chapman, and I'll be chairing these podcasts going forward. For those who are listening from within the Department of Population Health Sciences, you might know that this podcast series was previously a seminar series. The seminar series was fantastic. We really enjoyed running it. But we were noticing increasingly that people were engaging with the content remotely, so they were waiting till after the seminar had taken place and listening to the recording. So we thought, why not take that? Why not leverage the way that people are now engaging with this content and formally produce a podcast where we can more directly accommodate people listening remotely? So this is very much an experiment, and as part of that, you're probably wondering, well, what's going to happen to the collaboration element, the live question asking element that we had in the seminar series? You'll hopefully see that we've taken some steps to ensure that still remains through the podcast series. We're inviting co-hosts on each week to kind of engage with the speakers to keep that collaboration going. And you'll see, for example, from this first podcast that we've structured things to really invite collaboration with the speakers as a result of the podcast. So we hope you enjoy this new format, and we're looking forward to introducing today's speaker. And if you would like to suggest a speaker to be on this podcast, or indeed join the podcast as a co-host for a specific speaker, do let us know. I'm delighted that we've got Dr. Sridhar Venkatapuram with us today. And Sridhar's going to talk about ethics and equity research in public and global health. So Sridhar, I'll just read a brief bio for you, if that's all right. This is something that I've kind of pulled from one of your King's page, and then I'll hand over to you afterwards. And I think, as I understand it, the start of your talk is going to add some extra bio, so feel free to add or introduce extra stuff there to that. So Dr. Sridhar Venkatapuram is a senior lecturer, so that's an associate professor in global health and philosophy. He's based at the King's Global Health Institute, where he's deputy director and director of global health education and training. His research interests include health, inequality and social justice, global health ethics, and human rights in health and political philosophy. He aims to bridge normative reasoning with relevant natural and social sciences related to human health and health inequalities. So Sridhar's won numerous awards, grants, and fellowships. He's been elected to prestigious professional organizations, commissions, and panels, and is currently serving as an ethics advisor for organizations including the WHO and the International Resource Group for Global Health Justice. So Sridhar, really happy to have you here. Really great. Looking forward to hearing from you. I should also introduce Dr. Divya Palmer, who's our guest co-host today. Divya is a senior lecturer in global health, and so really looking forward to a discussion after the talk. So Sridhar, over to you. And like I say, I think there's some extra biography at the start of your talk, if you want to add anything else that you think people might like to know about you. Thank you so much for being with us.
Thank you, Martin, and thank you for this opportunity to present in this departmental seminar podcast. And I wish you lots of luck with the series. And thank you, Dr. Parmar, for joining us today and for helping out with this podcast. So what I'd like to do today is talk to you about my area of study and research and practice, but also some of my own research. So I've titled this talk Ethics and Equity Research in Public Health and Global Health. And so hopefully people who are interested in this topic are able to sort of either they might know something already, or they might actually not know anything and want to learn a little bit more. So this talk, what I'd like to do is start with the assumption that people don't know anything about ethics and equity in public health and global health. And then I'll also talk a little bit more on the kind of cutting edge research that I and others are working on at present. So to sort of just to do a little introduction of the whole talk, I'm going to sort of talk in three parts. One is that I'm going to introduce myself a little bit more. I'm going to talk a little bit about what ethics in public health and global health is about. Then I'm going to talk about my research and what I'm working on currently. And lastly, I guess I'm going to ask whoever is listening or watching to sort of do a couple of things. And so that's going to be how I'm going to end it. So hopefully it'll be interesting for all of you, and I appreciate you taking the time to listen to this podcast or to watch it on YouTube or however you are receiving it. So let me start with an introduction. As Martin said, my name is Sridhar Venkatapuram, and I am based in the Department of Population Health Sciences in the Faculty of Life Sciences and Medicine. This is a new place for me. So I was based in, or am based in, the King's Global Health Institute, which was an institute that was sort of set up to work across the university. A year or so ago, it has been moved into the Faculty of Life Sciences and Medicine, and therefore I'm also in the Department of Population Health Sciences, which is what brings me this opportunity to be able to present in this departmental seminar and podcast. Before King's, basically, I have been working in public health and global health for about well over 30 years or so now. It's a long time. I started off in my early 20s as really an AIDS activist in the US, in New York, and in India. And I started work not only by starting I guess what you would call a community-based organization in New York City addressing HIV/AIDS among the South Asian immigrant communities, but also the taxi drivers who were South Asian men. And so we were working on sort of alerting the community and these particular men about HIV and the fact that, it was sort of fatal, and you really do need to engage with the public services and public health services, et cetera. So from that sort of social justice and equity activism work, I worked, then moved to Human Rights Watch, where I was the first one to look at human rights abuses directly in relation to a health issue, namely HIV/AIDS. And so it was a project on HIV/AIDS related human rights abuses in India. And so I spent a couple of years monitoring all the different kinds of abuses that were going on, but also then doing a lot of work in India as well with one of the first batches of community-based organizations around HIV/AIDS in India, working with lots of different kinds of vulnerable communities, but also addressing policy, etc. So from there, I went to Harvard, where I studied public health and also was interested in human rights law and philosophy, etc. And so after Harvard, I was in New York City working for a little bit. And then I came to Cambridge to do a degree in philosophy and political philosophy. And the reason for all this jumping around is really one basic idea, is this notion of what is a human right to health. And so that can be another seminar, but basically in the 1990s and early 2000s, there was basically a division in human rights sort of work and human rights law and lots of other kinds of efforts that most Western countries, such as the United States and the UK, including the organizations based there, such as Amnesty International and Human Rights Watch, only recognize civil and political rights as being human rights, and therefore they only focused on monitoring civil and political rights. What the problem is that when you have a pandemic such as HIV/AIDS that is related to so many different kinds of horrible things going on, these human rights organizations really had a hard time, if at all, were interested in monitoring it because they thought of it as a health issue and a healthcare access issue and a poverty issue. And so my question was, well, what does this mean in terms of a conceptual clarity about what is a human right to health and what does this mean about human rights law, et cetera. And so what my PhD at Cambridge was about is a philosophical argument for a human right to health. And so it was published as a book called Health Justice. And so that has been going on for a long time. So from this argument about a human right to health that is grounded in philosophy and also public health and epidemiology and other debates that are going on, I spent 3 years working at UCL with a renowned researcher called Michael Marmot, or Sir Michael Marmot. And we worked a lot on how this notion of rights and health inequalities and social justice are related. So a lot of work and language that you see today about health equity and health justice really is coming from those period of time where we brought together the epidemiology of health inequalities with political philosophy and arguments around social justice and equity. So I'm going to stop introducing myself there, but just to give you a background that I am interested, and my background is really in questions around rights, equity, justice, health inequalities. And what I try to do is not only do the philosophy research and trying to figure out different kinds of puzzles and concepts and debates that have been going on for a long time, but also address real world problems. So when we are talking about HIV/AIDS, or I've also done lots of work on Ebola and what different kinds of issues that brought up. And I spent, about 3 years during COVID from the beginning, doing lots of different kinds of ethics advisory work at the London government level, but also at the WHO and other organizations, including starting a group myself, in which we are providing or had provided ethical guidance for different kinds of issues and policies. So what this does is that for me, it puts me in a really interesting position of being interested both in public health at a national level or local and city level, but also very familiar with and interested in global health in terms of not only LMICs and what we think about in terms of development and health equity, but also thinking about global health as what happens across countries and at the international system. And more now, I'm focusing very much on the ethics and equity of global health in that sort of transnational policies. What I want to do now is actually step back and take many of you who may not be familiar with ethics in public health or in global health and sort of talk to you a little bit about some basic concepts that we work with and how it relates to many of your work, your research, and potentially your future research plans and projects. Okay, so what I'd like to do now is, with apologies to those of you who are, experts and very familiar with what I'm about to say, I also want to, use this opportunity to provide some basic information to people who may not be familiar with ethics and equity research in public and global health. So let me start from the first kind of probably something that you're very familiar with. If you are an academic researcher in the health sciences, you are probably very familiar with the ethics approval process, and that might be something that you sort of understand or actually find a great sort of hindrance to what you're sort of trying to do. So those research ethics questions and principles that they are trying to get at come from a certain place and a certain reason for it. And they're also very much related to many of you who are medical practitioners are familiar with the idea of bioethics principles. You probably were given a day or two of lectures in your medical education, but you are very familiar with this idea that in a clinical encounter with a patient, you are supposed to reflect respect for autonomy, beneficence, non-malfeasance, and justice. And in some way or another, I think you've probably made sense of it and apply it in different ways. Most importantly, I guess, the most important ethics principle in clinical practice is this idea of consent. And you want to make sure that you get the consent of the patient before you perform any tests or operations or any different kinds of questions. And that sort of is very much related to this principle of autonomy in bioethics. So, while many academic researchers in public health and global health might be familiar with research ethics proposals or with bioethics principles if you are in healthcare practice, I bet very few of you are familiar with this idea of public health ethics or global health ethics. And so, what's happened is we are at a very kind of pivotal moment, and this has been not only because of COVID and the enormous amounts of social sort of problems and conflicts that is created, and around the world, what we are seeing now in lots of different other health arenas, but also because of what happened before in terms of Ebola, and before that in terms of HIV/AIDS, a lot of things. So what I'm going to try to do is try to trace for you a particular conversation or debate that happened in the late 1990s and 2000s that gave rise to public health ethics and what we would call global health ethics, which was that in health ethics, in sort of in the 1990s and 2000s, when we thought about ethics in related to health and health policy, most often people would focus on those four bioethics principles where we really paid attention to the individual and the consent and autonomy of the individual and trying to treat them well and respect and sort of think about their sort of what are the benefits that we can provide in terms of different kinds of healthcare, et cetera. But what happens with HIV/AIDS as an infectious disease is that the policies to address HIV/AIDS have to, in a way, curtail what we would call the autonomy and freedom and rights of particular individuals for the sake of protecting other people. So rather than the primary beneficiary of a policy in our act being that particular individual affected by a disease or a health condition, the control of infectious diseases really entails and requires sometimes that isolate the individual, that you sort of make sure that they have no contact, that even if they are unwilling, that you sort of impose various kinds of constraints on that individual so that they don't pass on potentially a dangerous infection to other people. So this conflict between that primary focus on the individual and autonomy and respect for the individual versus infectious disease control, where you have to think about constraining individuals, particular individuals, for the sake of the benefit of the many, really brought up this question that we need to think again about ethics in health, that it's not just about the individual. We also need to think about populations and public health. And then aside from that, another thing that happened during the late 1990s and 2000s is that we started to see a lot more arguments about economic efficiency in health policies and health cares. And what that means is that people started to show that in order to use our public finances in a more efficient way, we need to reorganize and rethink the way that we spend money in the healthcare system. And that requires us to think about fairness when it relates to the distribution of resources across a whole bunch of people. So it brings up questions about, well, do we sort of, pay for the healthcare of someone who is really sick, but, we could help five other people rather than one? Or we might say, well, this person really urgently needs this medication or their health services, they really urgently need it. Or do we help 10 other people who might benefit for the long term? What about, is it more important to help few people or is it more important to help other many people? So these kinds of questions around distribution do not have any technical solutions. They're not scientific. They are very much ethical sort of issues. And that's why you have today in NICE and in the United States and in other countries this idea of social values and collecting social values and committees that provide social values, because these are not technical biomedical sort of solutions. They are fundamentally a value based and they are intrinsic and inherent that go into health policy. And so that is another area that sort of has required us to think much more about ethics. But the third area, which is also really important, is that when I was telling you about HIV/AIDS and this idea that most infectious disease doctors and public health people understand and are willing to argue that we should violate the rights of certain individuals in order to protect the greater population. What we found during HIV/AIDS is that these certain groups of individuals that you would normally constrain their rights were unwilling and actually resisted that kind of approach. So what we might be sort of willing to accept 100 years ago among this particular group of people, particularly white gay men in rich countries, were refusing and refused to cooperate and were resisting this idea that somehow their sort of rights as a small group who was vulnerable to a disease could be constrained for protecting the greater good. And instead, what you had was a different kind of approach that developed, which we call the health and human rights approach. And that argument and that framework, which is still very prominent today, is this argument that if you violate various kinds of rights unjustifiably through public health policies, you are going to actually make the situation worse. And so in HIV/AIDS, we were able to show that if you make, sort of isolation, forcible testing, all these other kinds of implants, then people actually go underground and they go away from services, etc. So the framework that developed was that public health policies can violate rights in a variety of different ways. But also, the flip side of it is that individual rights and group rights and various other kinds of really important human rights, if you violate them, they will also make public health worse. So if you don't allow certain groups to meet, if you don't allow freedom of access to information, if you don't allow different kinds of information to flow very easily, etc., what you're going to do is actually make health issues worse. And we saw that with HIV, and we saw that with COVID. We're now seeing that with tuberculosis in the United States, etc. Is that censorship, freedom of, restriction of association, all these kinds of basic tenets of democratic sort of operation. If you violate them, you're going to make health issues worse. So the conclusion of that framework is that somehow a society that protects human rights, all human rights, economic, social, and cultural rights, and civil and political rights, etc., is actually going to produce better health, and the population is going to be much healthier. So while that was going on in the world of human rights, and really when we see a lot of human rights lawyers and other people who are talking about health and human rights, that's the kind of framework that they're working with. There was a huge other revolution that many of you are familiar with that was happening, which is this social epidemiology revolution, where we now understand and we are now able to show that rather than an individual level causal model of disease and disability and death, a model that incorporates multiple levels of social factors, not only at the individual family, neighborhood, city level, but also national and global. These kinds of social determinants of disease and death are able to explain disease prevalence much more, but also they're able to explain distribution patterns of health and disease much better than individual level multifactorial causal model of disease. Now, what that is showing is that when you have the causation and distribution of disease happening outside of individual control, it's actually happening in the social environment, from the social policies, from social institutions, then we call that and we say that's a matter of social justice. And so what we have here then during the early 2000s and more recently is this bringing together and coming together of social epidemiology that traces how social factors, social institutions, and policies cause disease and death, with political philosophy, the kind of background that I have, which looks at theories of social justice. What are the different kinds of ways we imagine a good society to work? And what are the ways that we can start to bring together our understandings of what social justice is with our understanding of the causation and distribution of disease. And so that is another sort of way in which ethics and equity is sort of coming together. So, and more recently, what we see during COVID is, lots of people for the first time understanding the idea that health is not just about access to healthcare. You have to think about what are the different kinds of pre-existing vulnerabilities in individuals and social groups, what sort of different kinds of inequalities are in the system, what sort of historical disadvantages and alienation do different individuals and groups face, so that when a crisis happens, all of this actually gets worse, etc. So hopefully, in this particular sort of part of this talk, I've been able to take people from where they are. So if you had known nothing about ethics and equity aside from research ethics, or if you know nothing else about bioethics aside from what you did in medical practice, what I hope to show you is this idea that beyond bioethics and research ethics, the infectious disease epidemics of HIV/AIDS, Ebola, COVID, and now other things that are coming have raised a whole different kinds of other kinds of ethical issues, but also showing how the bioethics principles and that framework wasn't enough, and we need to develop different kinds of ethics. But also beyond that, what I've shown you is aside from just sort of the idea of ethics, we have the idea of human rights and human rights law. And we also have now, much beyond that, this idea of social justice theories and social inequalities in health and health inequalities. So this is just a taste of trying to show how ethics and equity is not just a kind of add-on to a little policy, or it's not just something that you can think about afterwards, but these are ongoing debates and conversations that have been happening now for over 2-3 decades, thinking about social justice, thinking about human rights, thinking about how public health needs to change, and that sort of old traditional contain and control approach may not be the right way to go anymore, etc.
Divya, is there anything you'd like to discuss? I've got a few things.
Yeah, and we can cut it if it's too controversial. I was, because of all that's happening with the Trump administration and with the WHO, and, the cutting of funds for global health is, and probably for vulnerable populations or even reproductive rights, access to abortion services. What's what's do you think would be the long-term impact of these, or how will it basically harm the global sense of cooperation and, the way forward that we're moving? Because US is a big player, especially in global health funding. So how do you think that plays out?
Yeah, and so I think, well, there's two things. One is that this could be answered from a politics perspective. Like, you could ask a political scientist, well, what's going on? What's the power issues and interests here? And what are different people winning and losing in this kind of situation? I'm also going to talk to you a little bit about ethics in it, because that's what I'm interested in. What are the ethical principles and all this kind of stuff? So I think that so let me just talk to you from a politics perspective. So what happened is that for a long time, I don't know if you've spent time in the United States, most Americans actually have no idea what the World Health Organization is, and they have no idea what it does, and they have no idea what it's there, because in the United States, there is this sense that we are raised and we are treated as if every institution in the United States is the most important and most powerful institution in the world. So the US Supreme Court is told to us as being the most smartest and most important Supreme Court in the world, that there's nobody smarter than the US Supreme Court. In a similar kind of way, the CDC is sort of presented as this is the best health organization in the world, the NIH is the best researcher. So we are raised in the United States to think that there is nothing that could be beyond, above, smarter than the institutions that are in the United States themselves. So the World Health Organization has always been something that most Americans have never really understood, or what it is, etc. But the funny thing is that the World Health Organization is dominated by Americans. So if you actually ever go to the WHO, you will see that a lot of people working at the WHO are actually Americans, that a lot of the consultants that work at the WHO are largely Americans. So despite the fact that Americans don't know it and American government never relies on it, most of the people working on in the WHO are Americans. In fact, even the internship program until very recently was dominated by American public health students, etc. But what happened, aside from it being the largest funder, it also tells the WHO what to do with the money. So that's one basic understanding. It's what I would call and other people would call a pay-to-play program, which is that you pay. That means that you get to play in the way that you want to do. So you tell the organization how to spend the various kinds of money. And so there's lots of different kinds of issues already with that. But what happened when when Trump threatened to pull out from the WHO and actually tried or did, stuff, that essentially began a process in which the world and the WHO began preparing for the US to pull out at some point or another in the future. So I think that what you will see is that while the WHO was on a campaign to raise a lot of money because it needs more money to do more things that it wants to do, it also, and hopefully they've done it well, is that they've also began having a backup plan when the US, so whether it be Trump, but even after Trump, there might be somebody else, or there could have been somebody else who says we're going to pull out of the WHO and other UN organizations. So people have been doing that, preparing for that for a while. But in terms of it will be a big hit, it is a lot of money. And, I don't know how accounting works and whether money goes instantly or whether it comes years later or whatever. But I do know that the WHO is already cutting different kinds of programs and jobs as a result. But also the WHO, like any other organization, loves a good crisis because a crisis allows it to get rid of people it doesn't want, and it, sort of allows people to get rid of programs it doesn't need, et cetera. So that's probably also happening as well. But what it shows is, and then we can have another seminar on this, but what it's doing is that essentially creating space for other countries to become more important. So China is already stepping in and saying, we'll pick up whatever it is that needs to pick up. Germany then becomes basically the new dominant player in the WHO. So it raises other kinds of questions around what sort of values and program objectives that Germany has, etc. And then also you have the Gates Foundation as being the single largest private philanthropy, who's also significantly underwriting WHO programs. So that organization also becomes more powerful in the WHO. So those are, I would say, the political stuff that's happening. But in terms of the ethics stuff, I think what this shows is that one, I think I'm particularly not completely unhappy with the current state of the world, because what it does is that it reveals the true picture of things, which were often hidden with the rhetoric of, oh, we care about the world, we are all solidaristic around the world, and we have, health is so important to everybody, etc. And so that rhetoric of global solidarity and equity and every life has equal value and we must do something, all of that stuff has been taken away. And what you now realize is actually underlying all of that has always been these other kinds of calculations. So in order to read, I'm not saying that those values are bad. I actually believe fundamentally that every human being has a right to live and health and stuff. But in order to make that real, we have to make it real, not sort of allow rich countries who've been providing money to kind of give you the rhetoric of it, but not really sort of underwriting it. So we'll have to see what the kind of new ethics will come out of this, whether it's just going to be every national country sort of pursuing its own interests. So will it only pay for programs that benefit itself? Will it only pay for programs that are going to benefit its corporations that provide the healthcare and medicines for that program? Or is it going to be some sort of new kinds of ethics that come from other places as well? So I'm sorry, that's a long answer for
Yeah,
I
I wanted to just ease out the second part. So in terms of, say, reproductive health rights or LGBTQI rights, now, when a powerful country like US pulls out, or reduces access to some of these rights, how will other countries that, were anyway a little bit uncertain or were not really fulfilling the full agenda of these rights, how do you think they will react? Will they get ammunition now to be more against these rights? Or, how will that play out outside US, for example?
Well, so it's not about the future, it's already happened. So over the last 3 years in the World Health Assembly, you will see that a number of Middle Eastern countries, rather than focus on any of the big crises that were happening, they spent more time holding up the discussions because of things like reproductive and sexual health programs and other kinds of programs that deal with sex and sexuality. So what they were basically saying is we don't want the WHO to be working on these issues, right? And so this is the program of action. They would not approve of the program that the WHO should work on. So what's happening is that in this moment of the most powerful countries essentially having fights among themselves and not interested in the WHO, has been a moment in which other countries have actually moving forward in resisting various kinds of programs that deal with women's health, girl and women's health, also other kinds of sexuality and sex-related health programs. And so they've already been pushing forward and holding up the World Health Assembly as a result of that. So what we can see is we can expect to see in the future at the World Health Organization level, at the World Health Assembly, a group of countries that are becoming much more, because no one's going to hold them back. No one really cares anymore. The US isn't going to fight them, etc. So they're going to keep pushing to basically pull back all those programs around reproductive and sexual health for girls and women, but also sexuality and who knows what else that they might address. At the same time, I also want to tell you that it isn't always great when the United States fights for these programs. So what it did under Obama is that, people are like, oh, well, now Obama's president, we can, sort of assert our sort of role in global organizations to move forward the rights of women and LGBTQ populations, etc. The way that they did it was so aggressive and so American that they completely, in a way, poisoned the environment in the WHO and the World Health Assembly. That, just think about that standard American, like we are right and this is the way, and equality. I mean, no one's disagreeing that this is absolutely right and that's the position. But that sort of domination of the global health space that every American, whether conservative or liberal, does, has completely done, kind of harm to the global sort of agenda for sexual rights and also for reproductive health and stuff. So it's a mixed bag of, it's not that the United States was the greatest and best advocate. It's like sometimes, they've actually hurt the cause around the world as well. So we might look towards other countries and seeing how they are doing it in their own way. So, some of the LMIC countries are actually very invested in improving the health of girls and women and reproductive and sexual health. Some countries are very advocates of LGBTQ rights for a variety of different reasons. So we might need to also watch and amplify their messages and strategies for how they are doing that in the global sphere. So what I'd like to do now is talk a little bit about what I'm currently doing and working on. So I think the COVID pandemic for, sort of for 2, 3 years, I spent most of it actually doing a lot of ethics advisory guidance work, and really trying to think about what sort of research questions that it brings up and how to use all that work that we did and I did in relation to ethics to build sort of and push forward some new questions. So aside from that, there's been some continuing research projects that are now over, sort of 5 years in the running. So what I am focused on at the moment are a couple of areas. One is this idea around justice and older people. So I know that some of you and many of you in the faculty are interested in aging and healthcare and biology of aging and disease and aging, etc. I have been very much interested in this question around social justice and older people and looking at how different kinds of deprivations and health inequalities and premature mortality, etc., actually reflect different kinds of social injustice and how to think about doing justice to older people. I think that if we think about older people akin to other kinds of disadvantaged groups, you will see that there's a lot of similarities and arbitrariness, and it makes sense to think about it in terms of justice and inequality and equity. And so I've worked a lot in that. And so one of my arguments in some of my work has been sort of already adopted by the WHO and also the UN Decade of Healthy Aging. When you look at their concept of what healthy aging is, that's based on my PhD and some other work. And so I'm sort of trying to build on that in terms of sort of working specifically on rights of older people. The second area that I'm interested in, and probably the most interested in, is global health ethics. So I've talked to you a little bit before earlier in this seminar about public health ethics. Global health ethics is, something that's new and relatively even more sort of formulated and still developing. And it's this basic argument. And the basic idea is that, unlike the clinic where there is just the doctor and patient or research and subject, unlike in public health where there is a governmental body who's trying to deal with population at a public health versus sort of individuals and groups, at a global level, basically the primary agents that we're interested in are nation states, not individuals, not population groups. They're actually nation states. And increasingly what we have is corporations and international NGOs and also really, really rich people, or sort of these, ultra wealthy trillionaires and billionaires who have significant power over countries and organizations. So what it is that to be able to situate health in that sort of context of actors, but in light of this sort of breakdown of the world order and the chaos, and clearly, our revelation understanding that our global order is not good for the health of most people on this planet, and it's actually not even good for the health of most people in rich countries, that it's actually good for the health of very few people and benefits them, that we need to rethink the place of health in this global order, but also rethink the sort of principles for a new world order as well. So that's really sort of a second area that I'm interested in. 20 years ago, I was interested in this basic idea of human rights, but now really the problem is what's the system that would produce those human rights, and what is the actual global architecture that would be good for the health of people on this planet. The third area that I'm interested in is climate and health and ethics. And so unlike, some of you who are interested in sort of looking at the epidemiology of disease affected by climate heating, what I'm interested in is actually the ethics behind how the questions about climate and health are being framed. So a lot of, as you would probably understand, the way that we frame issues, whether it be climate, COVID, Ebola, etc., those questions are often developed from rich country perspectives and from organizations based in rich countries or global organizations that sort of think about things in a very different way than people who are primarily affected by all these different kinds of issues. So I'm working with a bunch of other colleagues around the world on this idea of epistemic justice in the framing of research of climate and health, and what people outside of rich countries and rich organizations would identify as being the issues that require research on. There's a lot more other things that I am sort of currently trying to do research on and write on, and unlike, and I've had to explain this to other people as well, is that many of you work with large surveys and large data sets. The work of an ethicist and a philosopher is actually not usually involving collecting data or collecting large samples or working with quantitative numbers, but actually just sitting and thinking through a variety of different kinds of problems and different kinds of debates that are ongoing. And so that tends to be the kind of work that I'm doing now. But also part of my work has always been for the last 30 years and continues to do so is to inform practice. And so I do a lot of ethics advisory. So I sit on the BMA ethics committee and the BMJ ethics committee, and more recently the faculty of public health. I'm the sort of vice chair of their ethics committee. And so what we're doing is essentially increasing public awareness about ethics, but also informing the profession about different kinds of ethical issues and ethical practice. And hopefully I will continue to be doing that in the coming years as well. And this seminar is partly a result of that same kind of effort of trying to inform public health professionals and academics about this thing called ethics and equity and how to incorporate it as well. So the last part of this talk, what I would like to do is basically ask for three things if any of you are still listening or watching this episode. One is that if you are a colleague in Folsom or at King's or anywhere else in the world, but particularly if you're a colleague in Folsom and the department and the faculty and the school, etc., and you are dealing with different kinds of issues around ethics and equity, then please do get in touch. I would be very interested in thinking about and thinking through different kinds of issues that you are working with or struggling with. We are unfortunately at a place where, in the 1970s and 80s, when people started talking about ethics and medicine, all the doctors said, well, why do we need ethics? We're such good people. We're saving people's lives and we're addressing health and disease. We don't need ethicists. We don't need ethicists to tell us that we are being ethical and stuff. So it's a similar kind of situation in public health where everybody in public health thinks that they're doing a wonderful, amazing job and they're good people and they're saving lives. And so what could ethics and sort of have to do with it? So I think that, anyone who is interested in sort of a conversation about, how could ethics and equity be related to what they're kind of doing, I would ask you to reach out and get in touch and we can have a conversation. The second thing is that I think people who are sort of interested in doing research and who are trying to do really important big research studies or small research studies and want to think about how to incorporate ethics and equity research into their study, they should also get in touch. I would be happy to work with people from the beginning on different kinds of questions that could be incorporated. It often tends to be I sit on multiple selection committees for research grants. It often is very beneficial for people who are doing different kinds of research now these days to show that they've been thinking about ethics and equity from the beginning and not something that they've thought about at the end, and also the complexity and breadth of their ethics and equity sort of questions and aspects often tend to be a strength rather than a weakness in most research grants and publications. Lastly, I would be very interested in PhD students who are practitioners, who are professionals in public health and global health, who want to focus on a particular ethical or equity issue, who are interested in doing some significant social change or policy change in their career, and are really looking for language and concepts that are grounded in, deeply in ethics and equity and justice. And so I would be very much interested in talking to people who are interested in doing PhDs like that, or postdocs if you know of any. So please do send them my way. So with that, thank you very much for your time, and I really appreciate you sticking with me this far.
Sridhar, thank you so much for your talk. It's fundamentally a great way to get to know you and what you're interested in and what you're looking for and who you're looking to meet, which is, at least from my perspective, really an important goal of the seminars and this format. And kind of also good for an ethics 101, I think you called it, which was really nice, a nice introduction to some topics there. we'll close shortly, but I think just to throw an idea out there, not to steer your future collaborations, but I think you mentioned data there and kind of potential interactions with people in the department who are working with data sets, which I think is quite a few of us. It strikes me that there could be a really nice intersection there in terms of potentially understanding more about social determinants of health and the kind of distribution in a population, and then potentially using that to kind of target some of these protective measures, I think you called them. And I think I personally, I'd be really interested in kind of to learn more about, probably not now, but at some point in the future, to learn more about the intersection of your work with tech, right? Because I imagine tech is having an impact here, right? So we talked about how protective measures can sometimes be quite isolating and end up then having the opposite effect, or you talked about that. So I guess I would think, what role is tech playing there in kind of potentially kind of innovating there, if for want of a better word. So I don't know if you had any quick comments on that now, or maybe something for the future, or Divya, feel free to kind of jump in, and then we can quickly close, I guess.
Yeah, absolutely. I mean, I could do talks and talks about
Yeah.
both of those things. So I do work, and I do think data is, big important. So I work with some of the best, empirical researchers in the world, like, at UCL with Michael Marmot. They work with data, big data all the time. So they really bring up questions around distribution patterns. So, numbers are numbers. They don't have any value, right? So people have to bring value to them. So what do we do in response to the numbers that we're seeing? Do we assume that, the right thing to do is always sort of in this particular response, one way, or are there many right ways to respond to these, quantified data? So those things I work on all the time. And the same thing with tech as well. So I've been working on, a few years ago, we started to do work around the ethical sort of development of tech in low resource poor settings. So, a lot of tech companies, startups will promise you that they're going to save the world, particularly the poorest people in the world will have access to things that, their tech will provide. But actually, once you give them the money, then they're like, well, we need to get as many customers as possible. So that actually means that they don't go to the worst off. They try to get to the ones that are easy. So how do we deal with this kind of dishonesty in the entrepreneurship tech in low resource poor settings context? And so how can we develop some really good ethical principles for doing something like that? So I'm very interested in that. I mean, I could talk to you more about other stuff, but I think that's the kind of conversations that I would love to have with people. And really, more than anything, if you're interested in ethics and equity, we will have something to talk about. And so I encourage you all to get in touch.
Sounds
Divya,
great.
did you have any comments or questions? I want to make sure you get the last word in this.
Yes.
Yeah, no, so I do a lot of global health research, and I think previously you had mentioned about, community consent and local ethics principles. Sometimes we go with UK ethics, you know, because we do certifications here and this thing, and it doesn't sometimes, merge well with what the ethics and morals or values of local communities is. And I think it's quite challenging to, have these kind of processes, and people, in UK, you're talking about equitable partnerships and all. But, in essence, it's very difficult to have them when you are coming with UK principles into a local context. So how is your experience of, managing these kind of expectations from a high income versus an LMIC context?
Yeah, and I mean, that's a great question. I think this is, more on the different kinds of research ethics regimes that are at play. So what's happened is that for a long time, basically many LMICs had very weak ethics oversight processes and boards. So a lot of researchers would just show up and do whatever they want and leave. And so we saw that, like in many LMICs, most governments don't know what research is being done in their country and what's happening to people and what's going on. And so therefore, I think there's been a push to get research ethics sort of regime stronger in rich countries, that anyone who's in academics, so this works in terms of publication sort of approval, but also research grant approval and stuff, to sort of tighten up the research ethics regime. What that means is that it's created this other problem that you were talking about, which is that suddenly people show up with their American research ethics or their UK research ethics. And so then they're like, well, how do we apply this? And they don't know. And so usually what's happened is that people kind of fudge it. They just sort of get through it and then they sort of try to make it up. More recently, what's been happening is that there's this idea that some countries and groups have started to develop their own research ethics principles. So particularly with indigenous populations, they've sort of started to develop their own sort of stuff. The EU has also started to develop a kind of regime where it says that you can't get away with just following the local ones. You also have to follow the European ones. So it's a double kind of, you have to integrate all these different kinds of research ethics. And if you have a multi-country study, you have to now do multiple country research ethics boards and the EU ethics boards, and you have to make sure that the community at the global, all of this is to say is that, this is to prevent, sort of the abuse and extraction of people in really powerless situations. But I agree with you. I think that what we need to think about is not only the inappropriateness of sort of, say, UK ethics research agenda in a particular context. What we are trying to show and what we want to do is actually show that the ethics principles are not, what we think about as ethics principles are very much really good and really powerful, but they were developed by certain people in a certain place, and they shouldn't be considered to be universal and somehow the truth and logic around the world. So it's not that that's West and we don't have any ethics in somewhere else. What we're saying is that these are really good principles, but there's also other ethics principles that we need to also identify that come from other places, and we need to figure out a way to bring them together. But only when people start talking about it will it change. Right now, people really hide it because they just want to keep their ground, or they don't want to make any trouble, and so they just don't talk about it. And hopefully what people like me and other bioethicists and ethicists are doing is that, look, we have a problem here, is that this is essentially one set of ideas being applied everywhere else as if it was universal truth, and it's creating a lot of problems. And it's not really what it's meant to do, and we need to think again about how to do things better, and include more people in the process.
Yeah, no, completely agree, especially when, communities and, institutions are involved. Here, ethics is very individual, right? You go to a person, they give you ethic, and that's it. But they live in a society, they live in a system, and there is no process as such of getting ethics or approvals within that system. But, if anyone who does global health research, that's the first step you do, is the kind of the community approval and permissions to do the research, and which really is not the process here, but which is quite integral to global health research.
Yeah. I mean, that's the kind of stuff. I mean, if you're interested in talking about it some more, I'd be very interested in talking about, because that notion that community engagement and community planning and community approval as being the first step is an important thing for people to recognize, because new people are shocked when they show up and they're like, what do you mean I have to spend 3 months talking to people? I have a study that I want to do. And so, that's what happens. But anyway, but thank you again to both of you for your time. I really appreciate this opportunity. And to anyone else who's still stuck with us, please do to get in touch with all of us or with me if you want to talk about ethics and equity in public health and global health.
Yeah, wonderful. Yeah, thank you so much, Sridhar, and thank you, Divya. It's for your
It's a
time.
very interesting talk. So yeah,
absolutely.
Learned a lot as well.
It's been a pleasure kind of listening in, and a great conversation, I think. So thank you so much. I really appreciate both your time, and I'm excited to see the kind of collaborations that come out of it. It seems like there's been one formed here already, which is great. Thank you so much, both.